Hi, my name is Dr. David Ogutu. I'm a consultant gynecologist and fertility specialist. Today I want to talk to you about prompt fertility assessment and treatment. Did you know that women are born with a set number of eggs and do not make any new eggs going forward? The average baby girl is born with about 1 to 2 million eggs, and about half of those eggs will die out in childhood. At puberty, most girls have in the region of about 500,000 to 1 million eggs, most of not all of which are asleep or dormant, but at the start of every cycle, a few eggs will be woken up. The number of eggs recruited in the course of the reproductive cycle depends on the egg reserve they were born with, but most eggs would be lost in childhood, at puberty, starting off with a very small number, and by the time women get to 30 years of age, only approximately 12% of their eggs are viable or of a good enough quality to produce a live, healthy baby. Fertility is mainly dependent on the age of the eggs, and in the course of a woman's reproductive life, they will only ovulate ovulate and release between 300 to 400 eggs. The younger we start our families, or the younger we get fertility assessment, and the younger we start our treatments, the better the chance of success. When should we seek help? The younger we are when we seek help, the better the reproductive outcomes. Fertility is mainly dependent on the age of the eggs. The younger the eggs are, the better the chance of success. Male fertility is also affected by age, though not as severely as female fertility. However, it's important to get help at the right time. For couples who have difficulties getting pregnant, if by a year of trying and the woman is less than 35 years of age, they've not conceived, it makes sense to get fertility assessment to see if there's a reason for the difficulties getting pregnant. In the vast majority of cases, the tests are going to be all negative, giving them the confidence that they can conceive naturally. However, if there are problems that are causing them difficulties getting pregnant, the earlier they're picked up, the better the outcomes. For women over 35 years of age, it makes sense to get the test if having difficulties getting pregnant after 6 months. For those over 40, sooner than 6 months. For women who have obvious gynaecological problems such as irregular cycles, polycystic ovarian syndrome, endometriosis, fibroids, heavy periods, they should seek help and assessment sooner rather than later. For single women or same-sex girls who are going to require fertility treatment with donor sperm or looking to preserve their fertility for the future, the younger they are when they embark on the treatments or get assessment or preserve their fertility in the form of egg freezing, the better their chances. The ideal age for freezing eggs is less than 35 years of age. However, there is no upper cutoff limit, so depending on the age at which they decide to have the fertility assessment and to freeze their eggs, it is still possible to freeze at any point, ideally less than 40 years of age, but the younger the better. What fertility assessment options are there? The initial step is to contact a clinic, such as ourselves, and we will have a detailed medical history, medical assessment to assess what may be causing the difficulties getting pregnant, or for those looking to plan their future fertility, to assess what their fertility potential is at the present and what it will be in the future to help them with fertility planning. The most common test we perform for women would be an AMH blood test, which is an anti-Müllerian hormone. It's a hormone produced by the follicles or potential eggs that have been recruited in a particular cycle and will give us an indication of the egg reserve. It gives us an indication of quantity rather than quality. The main determinant of quality is the age of the eggs. Knowing what your egg potential is in terms of egg quantity helps with deciding what treatments to embark on, when to have treatments, when to postpone treatments, when to postpone a pregnancy, or when to consider preserving fertility for the future. Other investigations would include a detailed ultrasound assessment, which is a two-dimensional as well as three-dimensional ultrasound scan. In some cases, we would be able to perform a procedure called hyposy to assess the fallopian tubes, especially for those who are looking to continue trying to conceive spontaneously, or for those cases where treatments such as intrauterine insemination or IUI are the appropriate treatment for the future, either using partner sperm or donor sperm. What test results would I expect to see? In the vast majority of cases, the tests will be normal. However, in a few cases, there may be problems such as uterine problems, including fibroids, endometrial polyps, some congenital uterine malformations, which is some malformations of the uterus that one is born with, which may increase their risk of miscarriage or affect their fertility. This are usually clearly seen on easy 2- and 3-dimensional ultrasound scans. Tubal blockage may be another factor. The ovaries will be assessed, and some of the results we may expect to see are ovarian cysts, or especially due to problems such as endometriosis. Polycystic ovaries will also be able to be determined on ultrasound scan, and if that is a cause for their difficulties conceiving, especially because of not ovulating, it is very easily treated with ovulation induction. For men, a semen analysis will be performed to determine whether they've got sperm, and as well as the quality of sperm, the numbers of sperm, how mobile the sperm is, as well as a proportion of sperm that's mature and proportion of sperm that's normal. What are the treatment options following fertility assessment? Following a fertility assessment, the options would be either no treatment, which is that all the tests are normal, the couple are young enough, they have a good chance that they could conceive spontaneously over time. In cases such as polycystic ovarian syndrome, where the woman may not be ovulating regularly, if the fallopian tubes are open and the husband has got normal sperm, then treatment known as ovulation induction, which is why we provide tablets to induce ovulation and enable them to conceive naturally, is an option. For couples having difficulties with penetrative sexual intercourse, either due to vaginismus or erectile dysfunction, then partner sperm intrauterine insemination is an option. Other options include treatment with donor sperm for single women or for same-sex female women who need donor sperm to conceive. IVF treatment is another option, depending on the sperm parameters and how the duration of time couples have been trying to get pregnant. Depending on sperm parameters, we may perform something called IVF with ICSI, whereby if the sperm parameters are suboptimal, we may have to, in the laboratory, help sperm to get into the eggs within the laboratory, to fertilize the eggs in the laboratory for embryo transfer later on. Egg freezing or female fertility preservation is an option for those not in a relationship, or those not looking to start treatment to get pregnant soon enough, and they'd like to preserve their fertility in case they have difficulties getting pregnant in the future. Egg freezing is successful, it's very safe, and with current technologies of freezing eggs, we've got good confident data that shows that the chance of success with these eggs in future is the same as if they were fresh. However, if you consider a 30-year-old woman who freezes her eggs at 30 because she's working, for example, on a PhD, not looking to start a family for quite some time, if she came back to use the frozen eggs at 37, she would have the same chance of success as if she were 30. Some couples may need to use donor sperm or donor eggs, either because for donor eggs, if they've got a very low egg reserve, if the age of the woman is advanced, or if they've been unsuccessful with treatment with their own eggs. What is the IVF process? For most clinics like ourselves, there's no waiting list for treatment. We would see you for initial consultation, get the assessment, and you should be able to start treatment usually within 1 or 2 menstrual cycles after the assessment. The vast majority of IVF treatment in the UK is self-funded because of poor NHS funding structure for IVF treatment. However, many couples who are eligible for NHS funding would be able to have NHS funding for their treatments. In our catchment area, we are fortunate that most of our local NHS bodies are generous in their funding up to 1 to 3 cycles of treatment, which gives couples a good chance of trying. How do I seek help? Contact us at Herts and Essex Fertility Center, and we will in most cases be able to see you within the week for the assessment and to start your treatment. Thanks again, and thanks for listening.